And okay, so no disclosures. The objectives are to distinguish risky drinking from alcohol use disorder, learn ways to manage alcohol withdrawal, describe some different pharmacologic approaches to decrease the chance of a return to heavy drinking, and to describe some briefly, not to minimize it, but I briefly describe some non-pharmacologic methods for treatment. So starting with how much is too much or too often, alcohol is very commonly used, right? So it's good to know how to quantify it, and especially know when we're concerned. Just returning to the basics about what is a standard drink in the US, because when we ask our patients, we need to make sure we know exactly what counts as a drink for the quantity and concentration. So again, just to review a few of them, a 12-ounce regular beer, it's about 5% alcohol, would then be equivalent, for instance, to 5 ounces of wine or 1.5 ounces of distilled spirits. And sometimes it's helpful to have a calculator, because it can feel like a lot of information, and trying to talk with patients about this. This one is from Rethinking Drinking, which is in the NIH website. And this lets you, it describes, these drop downs sort of have lots of different descriptions of how alcohol can present, and then you can put in the actual alcohol content of your beverage or your patient's beverage, the what is the drink equivalent size, and then calculating the number of drinks someone has. So why does this matter? Because risky drinking is really based on the amount. And then we'll get into alcohol use disorder, which for the purposes of treatment, we need to make sure we're distinguishing and diagnosing based on the DSM criteria. But risky drinking, as defined by the NIAAA, is for the following quantities, and for an adult who is not pregnant. So for women, this is no more than 3 drinks in a day, no more than 7 drinks in a week, and a man 4 drinks in a day, 14 drinks in a week. And so importantly, again, the reason for that, both the weekly and the daily amount, right, is if someone has 3 drinks in a day, okay, but if they have 2 drinks 5 days out of the week, that for a woman would be more than a total recommended amount, and should raise the level of concern. So how do we screen for risky drinking? So SBIRT, you've probably heard about for a while. I think we're continuing to hear a fair amount about, has good evidence in primary care, specifically for screening. So such that it has a grade B USPSTF recommendation, meaning it's covered by Medicaid and Medicare. Really what this involves is a brief approach. It can last anywhere from 5 to 20 minutes, can be administered by a variety of health professionals in different settings, but again, the evidence is strongest in primary care settings. And it's basically using this 5 A's approach of asking about use, advise, assess, assist, and arrange for treatment if needed. And the goal is really to reduce the risk of negative consequences of use, and really most useful in finding it when it's still in that not as heavy, severe range. So we screen by starting with a single question is what's recommended. Asking how many times, you've probably seen this on forms in the past year, have you, for a man, had 5 or more drinks in a day, or 4 or more drinks in a day for women, again, which is past that recommended cutoff for low risk. And if that result is positive, then you can assess the severity further using validated screens. I'll show you the Audit C, which is a very simple screen to use. Other validated methods include specific to particular populations, for instance, the MASG, more for a geriatric population, or the CRAFT, which is more appropriate for adolescent population with the questions used there. So just as an example, this is the Audit C. So you may, if the patient screens positive with that single question screen, and you administer this, this is perhaps a response you might get. So in this case, we have someone who circled, how often do you have a drink containing alcohol? She circled 4 or more times a week. how many drinks containing alcohol do you have on a typical day when you're drinking? She circled 3 or 4. And how often do you have 6 or more drinks on one occasion? Circle monthly. And so for the score for this person, you would get 4 ones, you get a score of 7. And then you see here that a score of at least 4 identifies 86% of men who report drinking above recommended levels or meet criteria for alcohol use disorder, and above 2 identified 84% of women. And so this would certainly, if they screen positive here, you would then proceed to assessing for alcohol use disorder. So how do we diagnose that? So as with many other substances, we use our DSM-5 criteria. And we have up to 11 criteria. I always learned of them grouped in terms of like tolerance and withdrawal. So those physical signs, tolerance, needing more to get the same effect, withdrawal, having those symptoms when you're not taking the substance. And then the 3 C's was had grouped as taught different ways, but cravings being one that was actually new in DSM-5. What left DSM from DSM-4 was legal, but cravings came into the picture. Compulsions, so this compulsions just to continue use despite the negative consequences being social, medical, a number of perhaps both physical, social consequences. And so once someone has met at least 2, so 2 to 3 of those criteria, they have mild use disorder, 4 to 5 being moderate, and at least 6 of them would be severe. Why does this matter? It matters in terms of making sure that we get them appropriate treatment, and that's what we'll talk about next. And it also helps in terms of like we work with a lot of students and residents here, and we encourage them to document at baseline how they're doing and meeting which criteria. And then over time, so you can kind of more objectively assess how your treatment is working, reassessing and seeing what criteria, if any, do they meet. Is our treatment working? If they're still meeting the same number of criteria, maybe that's a sign there that we need to adjust course and treatment. Okay, so just to touch upon treatment rates, pretty dismal still, despite how ubiquitous this disease is. Only about 6.5% of adults in the US and 5% of youth with alcohol use disorder received treatment in the last year. Less than 1 in 10 people in the last year received treatment of any kind. And 1.6% of people with alcohol use disorder reported receiving an FDA-approved medication. So we're going to talk about those. As with other areas in substance use disorder treatment and dismally in medical treatment in general, we see that racial and ethnic minorities in the US continue to experience barriers to both group treatment and in general to this to alcohol use disorder treatment, and this is especially experienced by women in these groups. So in terms of management, we tend to think of it in terms of both acutely, what are we doing to help someone stop alcohol, and then what are we doing to keep them from returning to use if that is their goal. And I will say, as far as their goal goes, it might not be completely stopping, and so that's important too in terms of which treatment, assessing them for that and kind of what modalities might be most useful depending on where they are in terms of their goal for either decreased use or stopping altogether. So in this first branch here, we're really assessing someone they are presenting either to primary care, ER, which setting, if they're in acute withdrawal. At that point, we'll just talk briefly about that. So we first need to determine if they're appropriate for outpatient versus inpatient, if they need inpatient management. I will say it's very often difficult to get that inpatient management, but the usual contraindication to outpatient would be if they've had a history of a seizure. Other things would be like complex medical conditions, pregnancy, even like severe prior head injury that would put someone at increased risk of seizure. Those are all things to assess for and recommend inpatient treatment if they are in those groups. But if someone is deemed appropriate for outpatient, so also important, and that is having adequate support at home to help support them through the withdrawal. Not an absolute, but definitely comforting requirement if that person is there too, that you can kind of explain what's going to happen at home. And if we do treat the initial withdrawal at home, we provide most of the time, unless it's been tried a lot, in which case we sometimes are going a different route, but by brief, I mean usually 5, sometimes up to 7 day benzodiazepine taper. And the reason that is in bold is because that's really the only thing that's been shown to help decrease the chances of to prevent seizure or delirium tremens. So for safety, that is what is considered the standard of care. We do consider gabapentin to help manage more light withdrawal symptoms. And carbamazepine also, in some instances, will provide that. Oxcarbazepine. These medications can help, but again, the benzodiazepine taper is the what's needed to help prevent seizure. And then we'll talk about the FDA-approved medications to help. I bolded naltrexone and topiramate as the off-label one that have probably the most evidence of the ones listed here, but we'll come to that next. So back to the managing more acute withdrawal. Again, we see here's a Cochrane review from now 15 years ago of 64 RCTs that showed benzodiazepines as effective against withdrawal seizures when compared to placebo, and there's really insufficient evidence for the use of other anticonvulsants in treating that. But they may help decrease drinking. They've been shown to help decrease drinking extent after the detox. And again, gabapentin may have some role in mild withdrawal. Here's just a reminder of the CWA scale. This is administered. We have this here in our clinic. Again, if we're trying to determine what range they're in, certainly if someone's scoring in the teens, we're considering inpatient versus a benzodiazepine taper. And if they are high teens or 20, at that point, we're usually administering that benzodiazepine here in clinic and depending on how they respond, getting them transported. I use different scales. I like this guide. Scales is not the word I was looking for. Schedules for medication administration for alcohol withdrawal. This one's a 2013 article from AFP. You can see here a few of the medications listed and what's recommended in terms of their fixed outpatient schedule, which we use over the symptom triggered, which tends to be more inpatient. Diazepam or Valium has a nice long half-life. I think this one is used more in Europe. We do have it here sometimes. We'll use it, but tends to have a little more reinforcing effect in terms of the benzodiazepine use. And so at our clinic, we tend to use lorazepam. And so I'll talk about that one, but chlordiazepoxide is also, I know I see that used a fair amount too. And also as diazepam has that longer half-life, can be gentler in terms of the detox experience with that one. So any of these are options. Lorazepam, you can see here, this is a suggested dosing schedule. It can be modified. We tend to give here 2 milligrams actually every 6 hours, as is shown on the symptom triggered part on day 1, and just tell the patient to hold that for sedation, or certainly if they resume alcohol to not continue it. And then on day 2, 2 milligrams every 8 hours, day 3, 1 milligram every 8 hours, day 4, 1 milligram twice a day, and then at night. And then we like to follow up closely with someone to make sure they're transitioning off of this okay in terms of their actual detox experience. But now we'll turn to talking more to decreasing the chance of a return to heavy drinking. You can see here this kind of showing more the neurobio framework of it all. This is from that toxicology article, which gives a nice summary of all of these treatments. But this is representing the 3-stage cycle. So it's showing here, you can see binge, intoxication stage, withdrawal and negative affect stage. and sort of that preoccupation, anticipation, craving stage. And really what this is showing is there's a lot of heterogeneity in terms of the experience in the brain, and also how that makes treatment complex, but also in that complexity provides a lot of different windows for where our treatments can intervene and hopefully provide some relief and help. So going to focus on these. So the FDA approved medications that we'll go through briefly are naltrexone, which again is coming both in a oral and extended release form, acamprosate, and then talk briefly about disulfiram, otherwise known as antabuse, which does still exist, but we don't offer unless someone is really like feeling like that's what's going to help them in terms of completely staying away from alcohol. It just doesn't have as much evidence of effect. And then we'll talk briefly about a couple of the off-label medications that are recommended by APA, a second line, topiramate, gabapentin. The next few slides are a little bit wordy. I'm not going to read them word for word because put you to sleep, but also time. But you can kind of glance over these. So naltrexone, this was our FDA approved first for OUD, not effective in the pill form for OUD, but effective for alcohol use disorder, FDA approved for that in 1995. So some of these have been around for quite a while. And then the extended release form, brand name Vivitrol, was approved in 2006. So again, this is our opioid antagonist. So just in light of that, this talk was originally kind of set up as a co-occurring alcohol use disorder with co-occurring opioid use disorder talk. The real point here that I'll draw from that is, again, a lot of our folks who have co-occurring AUD and OUD may be on buprenorphine or methadone. So certainly this is not an option for them because of that risk of precipitated withdrawal. And we'll talk about other options coming up. For naltrexone, we just want a baseline, but we wouldn't hold this from someone if we didn't have baseline liver function tests. We want to get those as soon as we can and then monitor them. Can be started while someone is still drinking, but found to be most effective once they've been off the alcohol. But we'll usually prescribe it at the same time as we're getting someone off of alcohol to make sure they have it at hand. And it's been shown to decrease sort of that euphoria experience with alcohol. And so if they have a drink, to decrease the chances of that drink turning into an extended lapse to heavy drinking. This was really supported, its use by the COMBINE study, which was the largest controlled clinical trial for AUD, pharmacotherapy trial. And in this trial, patients were randomly assigned to placebo plus either acamprosate, which we'll talk about next, or naltrexone, all with medical counseling at the provider visit, and then randomized to either having intensive psychotherapy or not for 4 months. And what was found was those who had the naltrexone with medical management and those with placebo plus the psychotherapy, intense psychotherapy, had the most substantial decrease in days drinking. So this was really what supported the use of prescribing naltrexone in the office setting. So next we'll talk about the second FDA-approved med, acamprosate, which is an amino acid derivative, weakly antagonizes those NMDA receptors. In so doing, it can also help alleviate some of the physical symptoms of withdrawal. It was FDA approved a little later in 2004. Its daily dose is a little bit wonky because it's 2 pills 3 times a day, although people, if that's really a hard schedule to go by, can be taken as 3 pills twice a day. Importantly, it's not metabolized by the liver, and so needs renal monitoring. And again, this might be a good one if someone says it's not an opioid antagonist. If someone is on opioid or MOUD, could take this. But its most important role seems to be in preventing a lapse in someone who's already been off of alcohol, and doesn't have as good evidence as a naltrexone, but certainly may be appropriate for certain people. So good to have in our back pocket. And then disulfiram, just briefly, again, this one's been around a long time, 1951. It's the one that with any alcohol contact can cause that awful disulfuramethanol reaction, which can be quite dangerous and certainly very awful to experience. Needs to have liver function monitoring and couldn't be used also in someone who has significant cardiac disease. And really, again, it's contraindicated, of course, unless someone has a goal of complete abstinence. Not really much evidence to support its use, but it's probably best if someone's taking this under direct supervision. It has the best effect. Okay, and then just in the last few minutes, I'll switch gears to some off-label medications, namely topiramate, because really this one has the most evidence. It's been shown to have similar evidence actually to naltrexone in terms of treatment of AUD. How does it work? So it antagonizes those glutamate and facilitates GABA function. And it was 7 RCTs have shown more days abstinent and less frequency of binge drinking than placebo. Again, this head-to-head trial as well, so partway down in the slide, you can see of topiramate compared to naltrexone, showed good evidence of effect. The thing about topiramate is that to get to that goal dose, so unlike naltrexone, where we basically give people the goal dose of 50 milligrams a day, maybe the first few days starting with half a tab, just so that they can tolerate it and not get nauseated or GI effects. With topiramate, we have to go a lot slower. It can take weeks, several weeks to get to the target dose of 100 milligrams twice a day. So we start with 25 milligrams even daily, and then twice a day, and gradually increase by about 25 milligrams a week until we hit that target dose. Or some people do well on lower doses, but they may have significant side effects. And importantly, it is teratogenic, so cannot be given pregnancy, and certainly we counsel women of childbearing age about use of birth control if they're going to be on this medication. And then gabapentin, I think we see a fair amount used because it certainly can help also with some of the anxiety and insomnia associated with alcohol use disorder or recently coming off of alcohol. Again, this is a selective inhibitor of calcium channels, so has that anti-excitatory action. Meta-analysis of 7 RCTs just showed effect on the percentage of heavy drinking days. This target dose for this is 12 to 1800 milligrams a day for AUD and for cravings. And so this again can be limited by sedation. And so you have to be cautious with that. Has some potential for misuse. So again, caution with that. Again, not given for preventing seizures. That would just be the benzodiazepine. So just to recap the APA guidelines, naltrexone and acamprosate are recommended for treatment of moderate to severe AUD. We want to, as much as we can, try to offer these to our patients, increase treatment availability here. And they also suggest the use of topiramate or gabapentin in patients who have moderate to severe AUD, usually after first trying naltrexone or acamprosate. And it does self-program, should not be used as first-line treatment. And just to kind of touch upon some potential treatments on the horizon, this is a very busy slide, but basically 2 ideas on it. There have been certainly, and I think we're hearing much more about the GLP-1, so there's been some conversation in the medical community as well about the use of psychedelics for treatment. In the past, I think there's been RCTs on LSD, and this one is our very own. The one on psilocybin is Dr. Bott. Our Dr. Bott is the third author on that. Dr. Bogenschutz, Dr. Bott study. This was a great trial looking at 95 participants who were randomized to psilocybin and Benadryl, diphenhydramine, all with psychotherapy. And it was a 32-week double-blind period that showed heavy drinking days of 9.7% for the psilocybin group and 23% for the diphenhydramine group. And also that the mean daily alcohol consumption was lower in the psilocybin group. But so a small but really nice trial. Hopefully there'll be more on the horizon with that potential. And then of course the one that's coming up a lot in terms of questions of where is this going and will there be more treatments available? This was definitely the hot topic at ASAM this spring. are the GLP-1s. So again, these are our GLPs are incretin hormones, which we see help with appetite regulation, but there's also possible interactions with the paths involving cravings and reward. There's a lot of these receptors throughout the mesolimbic reward pathway, and so that's also been seen. They're being studied also for other substances, some evidence for cocaine and nicotine use disorders. I listed 3 semaglutide, exenatide, dual glutide that have some been mentioned in some studies. This paper I found really helpful from the Lancet from 2024. That's a nice review of the studies. This was an NIHR funded review. It looked at just 2 RCTs. The others were observational studies, and they suggested the GLP-1 agonist could reduce alcohol consumption, improve outcomes in some individuals. We don't have like the sort of the bottom line yet. I think that everyone's asking like what's going to work, and that we don't have the definite like strong evidence this is what we're going to do for a particular medication, but there's a lot out there and there's ongoing work being done. And unfortunately too, there's a lot of limitation with the cost of these medications, So how to decide which medication to take? Considering the coexisting medical comorbidities. For instance, we talked about liver, kidney function, ongoing perhaps treatment with MOUD. What worked before? So prior experiences, ability to take medication at a certain frequency. So again, like the acamprosate is very frequent dosing during the day, or would someone benefit more from like the injectable naltrexone once a month? Considering the other psychiatric comorbidities is important too. There was a double-blind study looking at patients who had a co-occurring depression, and they had a higher rate of abstinence from alcohol with naltrexone and sertraline than with either alone. And then just at the conclude to touch upon the behavioral intervention. So again, this does not do it justice. And Dr. Plum does a much better job than I at explaining these, but just to talk about them briefly, the brief intervention. This shows, this has good evidence for ingesting less, so 1.5 standard drinks after 1 year than those who did not receive this. And it typically leads to 20 to 30% reduction in heavy drinking, and significant effect actually found for up to 2 years. Of course, our motivational interviewing, lots of evidence for that, found to be most effective in the first few months and with younger populations who are experiencing occasional heavy drinking but low clinical dependence. And then, of course, the mutual help and some AA groups, again, with caution that some of these groups don't support people being on medication. So always want to make sure our patients are aware that they try a group and it doesn't seem like a good fit, but there are others. And family involvement, when it's helpful, can also be shown to help reduce drinking. So I will stop there. Just encourage everyone to keep this at the forefront of your practice. Try to increase the rates of patients who are getting these treatments, and we'll keep an eye out for growing evidence of what else might become available.